Hi, I'm Kimra Ali in Charlotte, North Carolina, USA. Can dermotricological therapies be effective in dermatophytosis? My case subject is an 82-year-old female married for almost 60 years. She is on several medications to address cholesterol levels, diabetes, high blood pressure, chronic back pain, anxiety, and depression. The condition started 4 years ago. And she has been to several dermatologists which have done biopsies that were inconclusive. Dermatologists have been unable to diagnose the condition. Here's an image of one of the areas that are infected. You can see the redness, the alopecia. Also here is a comma hair. JB describes her condition as breakouts in and on her scalp causing pain, itching, a sensation of something crawling under her scalp, and alopecia. She has been prescribed creams and ketoconazole shampoo. JB has not been back to the doctor about the condition in 1 year. Her home health aide decided to help her by doing a Google search online for a scalp specialist, where she found me at the Advanced Hair Growth Clinic. Pathology of interest. Dermatophytosis is an infectious fungal disease that can affect the hair, skin, and nails. These are common targets as keratin is a food source for these organisms. These fungi belong to the genus Epidermophyton, Trichophyton, and Microsporum. Regarding the site of infection, dermatophytosis are classified as Tinea pedis, Tinea capitis, Tinea cruris, Tinea barbea, Tinea corpus, and Tinea unguium. This case study is focused on Tinea capitis. Superficial fungal infections affect around 20 to 25% of the world's population and are associated with interference with daily activities, poor quality of life, and healthcare expenditure. Fungal infections are an economical burden. Billions are spent on treatments. Most treatment options are antifungal creams, steroid creams and injections, and oral antifungal drugs. Because of the overuse of over-the-counter antifungal creams, dermatophytosis can be recurrent and resistant to the conventional topical treatments. This case study is designed to determine the effectiveness of alternative plant-based dermotricological therapies. Characteristics of Tinea capitis is alopecia, desquamation, erythema, inflammation of the skin, and scalp lesions. These images here on the right are general images of Tinea capitis, and these are some more of the severe cases. Trichoscopic characteristics of Tinea capitis are corkscrew hairs, comma hairs, and black dots. Psychodermatricological profile. Scalp disease and its symptoms: itching, bleeding, oozing, and its signs of flaking, alopecia, scarring, can cause physical and psychosocial distress to patients. According to Hung, the social impact of skin and scalp disease can be devastating, with feelings of embarrassment, decreased confidence, rejection, social withdrawal, and limited hairstyles. Interpersonal relationships are also often affected. Patients experience psychiatric disorder, most commonly anger, frustration, depression, and anxiety. These emotions also have a negative occupational effect. Patients can experience decreased work productivity and absenteeism. Pharmaceutical approaches to fungal infections. Antifungal agents: terbinafine, fluconazole, itraconazole, and greaseprevir. Although these antifungal agents have a high effective rate, they come with side effects. According to Lopez, conventional antifungals exhibit numerous side effects and possible drug interactions. All the antifungal agents listed have similar reported side effects, affecting the central nervous system, causing headaches, concentration difficulties, and dizziness, affecting the gastrointestinal system, causing diarrhea, nausea, indigestion, and abdominal pain, effects to the cutaneous system causing erythema, itchiness, and rashes, thus stimulating the search for therapeutic alternatives. Lopez says the almost limitless ability of plants to synthesize bioactive compounds of different functional groups puts them in the first line of research for new, safer, and potent agents to combat dermatophytosis. Capiderm offers such agents. Dermotricological Assessment. General objective: to develop and implement an intervention program focused on therapies to alleviate dermatophytosis and stop the spread of infection, along with minimizing the symptoms of irritation, itchiness, and desquamation. Specific objective: to conduct therapies for a scalp condition observed, possible dermatophytosis, along with symptoms of pruritus, desquamation, and the crawling sensation under the scalp. Assessment instruments: a micro camera, the CapiCam, client intake forms, also known as the consultation forms, and a one-on-one session with the client. Here are images that were taken during the initial visit using the CapiCam, our micro camera. Here you can see scaling. You can see redness and irritation. You can also see a comma hair, and here is a scab, which will be revealed later on that there's a scalp lesion under here as well. JB has completed the quality of life assessment. The score shows this condition is affecting her emotionally a lot and socially a lot. The hospital anxiety and depression assessment score was below normal, and the Rosenberg self-esteem assessment score indicated low self-esteem. JB is currently on the citalopram for anxiety and depression. Here's another image. You can clearly see the alopecia, along with some redness and irritation. Closer look, you have the comma hairs, the redness and irritation, what looks like black dots here as well. JB has patches of short hair near the top, crown, and temporal areas. Scaling is visible, short hairs and redness. An observation with the micro camera shows the subject has short hairs, corkscrew hairs, comma hairs, desquamation, erythema, and irritation. The health plan proposal consists of using Capiderm products. We have internal products to use as well as external products. The overall goal of the intervention is to develop and implement an intervention program focused on therapies to relieve dermatophytosis and stop the spread of infection, along with minimizing symptoms of irritation, itching, erythema, and desquamation. Here in the dark blue, you can see the different sessions that were done. Sessions 1 through 4 were weekly, sessions 5 and 6 were biweekly, and session 7 was done 3 weeks out from session 6. Here we have the formulations that were applied while during the in-clinic session. This dark gray area are the leave-on topicals that were done in clinic. And then the light gray area are the home topicals that were dispensed during each session for the client to use in between her visits to the clinic. Session 2, no topical was dispensed because she was still using her topicals that were given to her during session 1. Session 1, we have now exposed the black dots, some scaling. You can see the redness and irritation. Session 2, still see black dots, redness and irritation as well. Session 2, this is a different area of the scalp. You can see where the scalp lesion is now exposed. You can see the scaling still. You see redness. Here's a black dot and a corkscrew hair. Session 3, we have black dots visible. Also, the scalp lesion now is more exposed, along with 2 other areas of scalp lesions that are not as severe as this lesion here. Session 3, you can see black dots are still visible, along with redness and irritation. Session 4, you have more scaling. You have a black dot here visible, redness, and irritation. Session 4, you have a lot of scalp scaling. However, you also notice that the smaller lesions are starting to heal, and this larger lesion actually is starting to look a bit smaller here, so it's starting to heal as well. Session 5, same area. The scalp lesion, the tail of the lesion is actually closed up. The larger part of the lesion looks smaller. This black dot is actually above the surface of the skin, indicating that hair is regrowing. And session 7, you don't see any black dots, no redness and irritation, and this lesion is still healing nicely and closing up. There is still some scaling on the scalp. Conclusion. The psychodermatricological profile of this case study was below normal in all categories evaluated. This may be indicative of the possibility that the subject will not follow the recommended health plan. Despite this, the subject followed home therapies as recommended. After the 4th session, she was asked about the symptoms mentioned above, and the subject replied that pruritus and irritation were no longer present, and the crawling sensation was not as frequent. When asked during session 5 about her symptoms, the subject reported that she had not felt the sensation of crawling within the last two weeks. At some visits, the subject said she didn't feel the therapies were working, but when asked about her symptoms, she was no longer experiencing them. I believe that due to the decrease in patient's confidence in the amount of time since the onset of the infection, she is experiencing doubts. It is recommended that she talk to a health professional about her emotional state. It should be noted that the subject is constantly touching and picking her scabs, even though she has been instructed not to do so, as this can prolong the treatment process. It is important to mention that the patient is a diabetic and treatment may take longer than a non-diabetic. The subject still has 5 sessions of dermotricological therapies left. Thank you.